If you've ever sat across the table from a health tech founder pitching their AI product to a major academic medical center, you know the look. They came in believing that the hardest part was already behind them. The science checked out, the demo was clean, and then the meeting ended and nothing absolutely happened. So I wanted to bring someone on who's on the other side of that table. Not a critic, not an observer, someone who's actually running one of the largest academic medical centers in the county, actually the country, and deciding every day which bets are worth making. So Dr. Marschall Runge has been the previous dean of the University of Michigan Medical School and previous CEO of Michigan Medicine. And today he's actually doing a lot of great work in cardiology, including work with Indian Health Services and the VA. So Michigan Medicine treats more than 5 million patients across one of the most complex health systems in the country with a research enterprise, a medical education mission, and a clinical delivery mandate that has to coexist. And sometimes they actually compete every single day. So Dr. Runge is a cardiologist by training, has published hundreds of papers, a novel, which I just found out about, a nonfiction book, and he has led major institutions through the kind of tech transformation that most consultants write about from the outside. So today we're going to talk about what academic health systems actually need from health tech and what most vendors get completely wrong before we even get to the contract and where the honest gaps really are too. So we're going to talk about AI adoption, in physician authority, and who actually gets reached. So Marshall, welcome to the Clinical Realist.
Thank you, Sarah. It's great to be on your show.
Great to have you. It's such a treat. So today I want to start with something that I think will be useful to everyone listening who has ever legitimately tried to get a product or a service into a system as complex as Michigan Medicine. So what do you want to tell health tech founders who think they just need to get into a major academic medical center? What do they actually not understand about how these institutions work?
Well, first of all, let me just say it's an exciting time with very innovative people, very entrepreneurial and innovative people who are potentially bringing AI solutions to healthcare. And I talked to so many of these folks particularly in the last several years. Some were our faculty, but many were not. Most were not. And they brought some really fascinating potential uses of AI. What they did not realize is while they were developing that, I mean, this is my opinion, but what they didn't realize is that it's almost impossible to do bolt-on programs. And what I mean by that,
I understand this. Yes,
we're owned by Epic right now, and Epic fiercely prevents any adoption of any external programs, and so we just can't adopt anything without ourselves having to maintain it, and that we went through that phase more than 10 years ago, way before AI, and found it was just hopelessly expensive and complicated because in a year, what was perfect a year ago is no longer fitting quite as well. And so it requires tremendous programming support. And we spent awful lot of money on that and time. And it was frustrating. And so people will come with these great ideas and I tell them that. And they're like, yeah, but you don't understand my idea. It's so great. And I say, I understand your idea. It is great. But you need to understand that you need to partner up with somebody before you come and give them a pitch and say, how can we work with you? And generally with us, there are two major EMRs. We use Epic. Epic is difficult to get to adopt external vendors. Oracle is very different. I mean, they're come all, bring all. And I think it might be easier for some of those folks to work with people that use Oracle as their primary electronic medical record than Epic. That's where I come from. And so
I appreciate that, yes.
It's so disappointing to them because, I mean, they really do have some ingenious products, but I'll bet if we took 1 out of 100 that were pitched to us, I'm trying to think what that one was. It's just legit. And the IT folks, I mean, they don't want to do it either.
That's true.
So that's the big hurdle, I think.
I appreciate that. Having been on both sides myself and having been at Oracle when we acquired Cerner and seeing
right?
kind of this,
very
it
cool.
is.
I didn't know that.
So yeah, I assisted with the acquisition and seeing kind of the spaghetti on the back end. I know is one of the major pieces that Oracle Health had done was they wanted to be that open organization. But again, a lot of people have Epic and it's been in their system for decades. And once it's in, it's very difficult. You're married to it for sure. Now, this kind of brings up something I've been thinking about a lot. So when you think about academic medical centers, they kind of have three different jobs simultaneously. So you've got teaching, you've got research, and you have to actually deliver care. And I think a lot of vendors think they're selling to the clinical delivery mission, but those three missions kind of share the same doctors, the same infrastructure, the same budget. So when some of those vendors kind of show up, assuming that they're going to work with your Epic or Cerner system, whichever you have, and they're pitching those clinical tools, which of those three missions is the most likely to get shortchanged? And does the vendor even know it?
Another great question. And I think it's ironic, the one that gets shortchanged the most is the educational mission. The reason I say it's ironic is that's the easiest one to get into.
I know, right?
Because, research has its own boundaries. Clinical care has its own boundaries. There's no NIH for education. There's no necessity that those things have to interface with the electronic medical record. So it's interesting because then I'll say, well, we might be able to use this in our educational programs, and they're like, not interested, because that's not where the money is, and
True.
It's not where the impact is. The other comment I want to make is one that you'll understand perfectly, and I hope your listeners do, which is from a clinical perspective. And it has to do with AI advances. And I'm going to give you one example around digital imaging. So it's been long felt that that's a great strength of AI. And I do think it's a great strength of AI. But I think and so we get hit with that all the time. Well, look, we could help you with digital imaging. And I think where AI is really effective is in defining normal. Where it gets more difficult is defining abnormal. And the example I'll give you is, about a year ago, there were several papers published in big-time national press about AI in mammography, showing how AI was better than radiologists. There's one study that compared mammographers in the United States where a single person interprets versus in one of the European countries where two people interpret, then AI made it even better. And that's good, and I like that, but none of those studies that I have ever found actually have a clinical correlation. So you'll get this. So great, they find some abnormalities. Did it turn out to be biopsy positive? Or were half of them biopsy negative, and women who had those things biopsied were exposed to risk with no real benefit?
Yep.
So great on the negative side. I'm less convinced, even with digital imaging, using mammography as an example, that the correlation is quite there yet in the diagnostic side, because you got to have more than just an image. You have to have some way to verify that image is valuable.
I like that. So, and I've seen this too. The AI is showing something,
Yes.
and they're pitching some sort of value, but sometimes the economics are off. So is it value for the hospital, value for the imaging company, or is it actually outcome value for the patient? And sometimes those are hard to define. But I do appreciate that, because being clinically significant is different than working as designed.
Yeah, and you hit something exactly. You hit the nail exactly on the head. I mean, at the end of the day, and this is what you say when you speak and in your book, it's about the patient. I mean, yes, of course, healthcare is whatever it is today, 18% of the GNP. But,
Yes.
And healthcare systems that don't make money go out of business or get bought. So that's a reality. We all understand that. But on the other hand, we want to do things that both meet our financial goals, but absolutely are good for patients.
So let's kind of zoom out for a second. Michigan Medicine, Ann Arbor, Michigan. The patients who need the most complex, most specialized care often live nowhere near Ann Arbor. So there's communities that are 50, 100, 200 miles away that are never going to get a cardiologist like you on staff. So what's the actual clinical infrastructure being built to reach those communities? And where does AI actually fit into that picture? And honestly, not aspirationally.
Well, this was something we started facing way before AI was on the scene, and that is we were a huge academic medical center in a tiny town, and 1,000 beds and 5 million outpatient visits, as you mentioned, a year. 5 million patients, 2 million outpatient visits, but 5 million patients we cared for, and many were from across the state. So our first goal was to develop partnerships across the state, and that was helpful. And we own a couple of other health systems, one in Lansing and around Lansing, and one in Grand Rapids and around Grand Rapids. But that didn't really serve everybody either. And so what we have been moving toward, and this is where there's some products that I think have great value. I haven't seen the best one yet, I hope. But this is the integration of technology and telehealth. So telehealth, I mean, I think most of us have that down. And most patients, when they're very happy with telehealth. If they don't need to have a physical examination, they're very happy because they don't have to drive, find parking, all that sort of thing, and they can have really almost next day access. The challenge is that how do you get some baseline information? If you have to have a extender there, even a medical assistant, but a nurse or a nurse practitioner or a PA, that introduces probably wasted time and a lot of expense. So I have seen demos, and as I said, I hope there's a better one out there.
There better be, right? There better be.
Sort of these stations, which are inexpensive. They can be located in rural areas, and the patient goes in and you get real-time vital signs. You can get other real-time information, clinical information. The vital signs, I think they've mastered that. They get blood pressure, heart rate, et cetera. But getting additional clinical information, I think, is just on the verge. And so what do I mean by that? Well, you can't examine, you're a surgeon, you can't examine the abdomen that I know of with any way. But from my standpoint, what's important is the cardiac exam, the pulses, the pulmonary exam. Those things, there's technology to provide information on those. Weirdly, really weirdly, about now 25 years ago, I worked in Galveston, Texas, which cared for the state prisoners across the state of Texas, huge state. And they had developed this technology. It wasn't great, but it was like a digital stethoscope and a digital ophthalmoscope. Ophthalmology's gotten pretty good at it.
Yes, it has.
So I think if somebody can come up with a cost-effective way to do that, and I think it's like all these technology barriers. It's expensive to develop, but then probably not as expensive to expand. I think that would be a big win-win because Michigan's, it's half rural. And you mentioned when we were talking before the show that you work in a pretty remote clinical setting.
We do.
And you can get specialists in this way. You can get all the things you need. So short of being able to actually put hands on a patient. So I think that's a great opportunity, needed, and the technology's there, but somebody's got to put it all together. And it's more complicated than saying, well, here's an app. Just put it on your phone.
Yes. And I think also, I'm actually giving a talk tomorrow, and this is one of the main points I'm putting out there, is that every healthcare system actually has a telehealth component already in there.
Right.
It's live. In 2020, we got these things rolling in a matter of weeks or months. And at the time, we had upwards of 30% of patients utilizing telehealth on a regular basis, on average over the United States. And now that we are more in person, those numbers have gone down, down, down. However, I think it's because the systems just aren't pushing them as hard. They're already paid for. There's people who know how to utilize the systems. It's already integrated for infrastructure. I also think this is an area where we have the massive amount of, I'd say, reach for patients, like you just mentioned, with or without the additional devices that we'd love to have. And it's something that could really decrease the pressure of our in-person clinics dramatically.
I couldn't agree more. I mean, we can't thank COVID for very much, but we can thank it for telehealth.
We'll thank it for that. That's the only thing I'm going to give it.
Yeah, it helps with access. Access is a real challenge in many settings. It could be used locally to reduce ER visits. Our ER is jam-packed because people don't have anywhere else to go. And particularly people who don't have, readily available physicians. So they come to the ER for their routine care. In our ER, probably 20% of the people need to be admitted, and 80% there are there for some kind of wellness check.
Exactly.
So yeah, I think that that's a great example of where technology can be helpful to us.
Well, let's talk about something I think some people in the room are going to get squirmy about, but let's see if we can save some people a lot of time. You and I have seen hundreds of pitches. I'm sure you get a random email almost every other day. I know that's how it is for me. And I've sat through a gazillion demos. I'm sure you have too. And I know we've both probably signed some agreements and walked away from a lot more.
Right.
So when a vendor comes to pitch their newest clinical AI, their newest gadget, when you're looking at them, what are the 2 or 3 things they do in the first meeting that immediately tells you they don't understand how a hospital operates?
Well, a profound question. I'm just thinking about it for a moment. I think that the biggest mistake they make is to perseverate when you say, well, we have to understand how this is going to work with our systems. They perseverate with the belief that if the person they're selling to understood how great it is, then they would figure out the solution. And big systems just aren't going to try. So I think that's the first misstep they take. When they hear which was kind of the first thing always out of my mouth, well, how are we going to make this work in our system? They should pause for a second and say, okay, let's think through this together, because then you think, well, maybe I have a partner that I can work with here. So I think they need to understand it's just not all about how great their idea is or their technology. I think it wouldn't be a bad thing, and I have sometimes told people who just keep going on and on, I've said, look, we get these pitches every single day, and we rarely take one, and it's because of this reason. Can you help me with that? And then they one more time go through how great how transformational it's going to be.
I can't tell you how many founders, even on teams I've been on, I have arm wrestled with, because even if you don't have existing integration with the system, you at least have to have a plan. So if you have a plan to integrate with Epic, Cerner, whatever the clinical piece is, I will listen for 5 more minutes. But if you have no plan, then I know that you don't understand exactly what you just mentioned, the importance of it being part of the workflow and an area where doctors, nurses, and other organizational members can actually access it in stuff they already know today. Because if it's something I have to log into over here or go to a different device for, I'm just going to say no. Because my doctors already are upset with the administration. My doctors are already exhausted and seeing way too many patients. If I add one more thing, it's going to be the straw on the camel's back, if you know what I mean.
Yeah, and if this is maybe a poor example, but when they come up with something really great that does work, in my leadership roles, I mean, it was a great day if 51% of the people agreed with the decision I made and 49 didn't. But with ambient AI, so with either a bridge or DAX, the Microsoft approach, where and I've never had a patient say, no, it's not okay to do that. I always ask them, okay, if AI listens, and we'll get your report and you'll get to see it. That has been, that I have to say, I think 75% or 80% of our physician population, was ecstatic once they had a chance to try that, because it saved them time. So the reason I bring up that example, maybe there will never be another example like that, but if they find things that can save the staff, not just physicians, save the other staff time, and what you mentioned was just the opposite, which is often true. Well, you got to log in through a different system. I mean, golly, in cardiology, we're still getting back almost over the days where the echo system's one, the cath lab's another, and you have to log into them separately. Apollo, you're like messing around with that thing forever. So So that's another. I hadn't thought of it in that way, but that's a great tip to give entrepreneurs. Figure out how it's going to save people time.
Well, let's talk about that time. When we think about nursing and physician burnout, I also love ambient listening because, again, completely in the workload, in the flow, and theoretically giving providers more time to make eye contact, more time to not be up all night making notes. But a lot of times in practices, that time is not given back to the
Right.
provider. Instead, it's actually to see more patients. Now, again, this helps with our access problem. We can bring more patients in. But from a burnout perspective, my concern is that it's actually making things harder. You've seen this at scale. What have you seen that's working or not?
Well, in our system, it's a little bit easier to control because we have centralized scheduling, which is not all that great. But and actually, I think AI can help tremendously with centralized scheduling. But we we have a strong practice plan that looks at expectations, and so we have set expectations for different kinds of clinical practice. And dermatologists may see 40 patients a day. A psychiatrist or a neurologist may see 10 patients a day. And so those expectations there, and I don't know how often this is violated, probably all the time, but the expectation of the practice plan is if you want to adopt a new tool and then want to increase demands, and it's always around RVUs. If you want to increase demands, then that has to be approved by the practice plan, which I think, I'm sure chairs have figured out how to get around that, but it does help with this problem. But I've heard that problem many, many times, some from our own physicians, but particularly from our affiliated physicians. They say, well, what good did that do me? Now they just piled on more patients. And everyone understands that access is a problem, but they don't want it to be solely on their back to fix the access problem. And I do think, the other comment I'll make, although I have not done this, but we have some pretty good success stories of people who've used AI as a extender, not a replacement, but they're using AI in ways that are available through Epic, I think, to gather information just as you would with, it's like an assistant. Does it take the place of a medical assistant, but it enables the physicians to work more quickly.
I like that. So when we think about, we've said yes to a pilot. We think that maybe they understand healthcare. We think it's a promising technology. When we deploy an AI tool and the pilot actually goes well, the numbers look good, the vendor writes a case study with us, wonderful, and 6 months later, the tool is quietly not being used anymore. What happened? Not the press release version, but what really kills a promising pilot even after the initial deployment goes well?
Well, I'll complain about our own system. We're very slow to make change, and we do pilots on our pilots, and
That's a good way to put it.
it's just hard. But I think the biggest, it's almost like thinking about the political landscape in healthcare. Who's going to change it? It's not the two polarized political parties. It's the people, and so I'm a believer. I'm a hopeful believer that if the people finally stand up and say, "Hey, this is not acceptable. What's happening in healthcare," that could pressure politicians to make change. The corollary is in healthcare. If the providers, if they reach, I think the pilot has to be big enough that they reach a group of highly enthusiastic clinician pilot members, and then that spreads. That spreads like wildfire. If it's a little small group, people say, "I know that person." They're always wanting to thinking only of themselves, and so they need to have a large enough pilot that it will have some oomph, and then that's what carries it. So we've seen both situations that you described, pilots that went great and were quickly adopted. Again, harkening back to the ambient AI, that was one. We did a pilot of about 100 people. We have like 3,000 faculty. But those 100 were so enthusiastic, it just zipped through. We've had others where it's a group of 50 or 100 who they tend to have a much more focused interest. And so maybe there are 50 people who are interested in the GI system. It's just not going to have that impact. Everyone's going to say, well, how does that impact what I do? So I think they need to think about their audience and think about the size of their pilot. Of course, it's harder to get a big pilot going than it is a smaller pilot.
True.
But I think it is a pathway to success, so they don't just get stalled out. But I think what happens when they haven't heard anything for 6 months is although there was a group of people, my light went off here, that were enthusiastic, it just wasn't a big enough group to carry the day.
That's interesting. All right, so a pilot has to be big enough so that the clinical champions are not just one person, but a small coalition so that the success of the pilot and the enthusiasm can be spread more wildly.
Yes, by people that are there. So
respected people that are there. Yes.
It's one thing to have a glitzy publication and press release. It's another to have people say, well, hey, wow, I tried this.
Yep.
It worked.
So that's interesting. So one of the things I see is, again, the very enthusiastic clinicians are part of the pilot, and then it goes to the other department or the other hospital or the other building, and it's people who are a little bit not so excited about it. And when we think about digital health deployment, there's often times where physician clinical judgment kind of runs into someone else's decision, either IT governance, legal, finance, C-suite discussions, procurement, compliance. So where does the physician's authority actually end in a digital health deployment? When should it end, and when does it get overridden in ways that kind of create a real clinical risk? What do you think?
Well, I think that physicians they must be involved, and they must help identify pros and cons of the technology. Now, at the end of the day, they don't make the decision typically. I do like, obviously I was in this role, I like physicians who are in the leadership role because I think they interact differently with physicians than people do who don't really have a strong clinical background. So I think that's one thing. You brought up something that triggered a thought in me. So with ambient AI, the system that we bought bonded with, whatever, in Western Michigan in Grand Rapids was called Metro Health. Metro Health had been using ambient AI for 2 years before we adopted here. And they had great experience. And I think it was largely their push that got our pretty risk-averse IT group to say, well, let's take a look at this. And so the reason I mention that is maybe where there are large systems, maybe that pilot could take place in one of the smaller components because those smaller components tend to be much more flexible.
True.
So
very true. Something
to think about for entrepreneurs.
All right, so now it's time for us to say the quiet part out loud. So I want you to think about something, and I think this is an interesting one. So we can both name the things that academic health systems are supposedly not prepared for. So interop, staff shortages, payment model transition, that's the usual list. What are academic health systems genuinely not prepared for? You don't have to call out Michigan, but in general, in the next 3 to 5 years, and not the obvious answer, but the one that actually keeps you up at night.
Well, it's this balance between adopting and not adopting new innovation. And not just in AI, but particularly in AI, but in AI in devices and AI in everything. That technology is roaring along. And as with much technology, there's a balance. So if you jump out and hook onto the first one that's out of the gate, that's probably not the best one, but it is the glitziest one. You can be in Becker's Healthcare talking about what you're doing.
You can get in Becker's for a lot of things, not necessarily always positive.
Yeah, maybe that's not. But anyway, you can get a lot of street reputation for doing that. On the other hand, if you put off technology, as we have done several times, you're just putting yourself behind. And so let's take a practical example of AI, and this has to do with the revenue cycle. So we live in a very difficult commercial insurance environment with a very dominant single commercial insurance company, Blue Cross Blue Shield of Michigan, that owns about 80% of the commercial insurance in the state. So they have no real competition. And negotiating with them, and we just completed a negotiation. I didn't, thank goodness, have to participate in this, but it's always about rates, and but a big part of it's about denials, about all the things that go through the process of getting things approved, pre-approval, etc. It turns out I didn't learn this until about a year and a half ago, but Blue Cross Blue Shield of Michigan, like many insurance companies, commercial insurance companies, probably like CMS, I don't know, they use AI, and they use it for prior approval and for claims negotiations. It takes like a couple of minutes, and then they send it back. And so we should have known, and I don't know if we knew that or not, if our IT folks knew that or not, but we're just now starting to use AI. So it's like battling computers.
Yep.
Had we done that a year and a half ago, I'll bet we would have saved tens, if not hundreds of millions of dollars in just churn time and revenue cycle and human time. So I'm giving that as an example of a technology that you wouldn't think of off the top of your head, but one that emphasizes this point of don't adopt too early, but be ready. When it's ready, be ready to implement it. And I think particularly at large health systems, particularly large academic health systems, have trouble with that implementation because in a way you have many points of disapproval. So you have to convince those people, whether they're clinicians or in the business side of things or whatever.
So one of the things that keeps me up at night is our aging population. So if we look at countries like Japan with a super aged population, they're many years ahead of us, and they're truly having a hard time taking care of so many older individuals with comorbidities. And I think there's a space for technology to help us scale, but at the same time, with increased numbers of comorbidities in patients, increasing age, less healthcare workers to do the job, and a general decrease in the trust of the healthcare system at large, my concern and what I'm seeing is more and more complex patients, less and less people to take care of them, more and more people on Medicaid, Medicare, and reimbursement being terribly low. So the margins are even tighter, and the incentives for people to go into medicine, I feel, are getting maybe not as shiny as they once were.
Well, you did a great job of putting that together. I'm not sure I can add too much to it, but I will
drop that mic and walk away, right, Marshall?
Yeah, that's right. Well, you've identified. I mean, there's a big mismatch of providers in the aging population. There is an increasing mismatch of a terrible mismatch in primary care and the needs. So, as I was studying this a year or two ago when I was working on a book about healthcare, you look at healthcare costs in the United States. I mean, we're way high, about $13,000 per capita per every person in the United States just to provide our healthcare. That's at least twice as high as most places, 3 times as high as others. But when you look at the number of primary care providers, we're at the bottom of the bucket in terms of how many primary care providers we have per capita. And that gets to a point that you mentioned. Primary care doesn't pay very well. And it's not likely to start paying well if we continue what we're doing because with our payment models, in addition to poor payers, in the state of Michigan and nationally, there's a significant number of people who don't have any insurance. Mm-hmm. And we're going to take care of them. You'll take care of them when they come to your clinic. We'll take care of them. And but you can't pay for that. So in my dream world, which is truly a dream world, I think that we need to appreciate that the RVU system was developed for Medicare back in the late 60s. it's not been tinkered with hardly at all since then. I mean, some diagnoses and subdiagnoses have been added, but it's a 50-year-old system, and I think the salvation, which is probably not going to occur in my lifetime, is to rethink healthcare and how we provide it and how we pay for it. It is true that healthcare in the United States is much more of a capitalistic approach than anywhere else in the world, and we have to address that head up. I was talking to somebody about this the other day, and they said, and I haven't done this. Maybe you've done this, but I'm going to do it one of these days. Well, take your favorite AI engine and say, here are all the problems. If you were going to redesign healthcare in the United States, what would you do?
All right, I'm going to do it right now while we're on the line together. So I'm going to open my Claude. I'm not going to share my screen, but I'm going to say, given all the healthcare problems in the U.S. today, what's the first one you would fix?
And how?
And how? Oh my God. And how? All right, it's chugging away. Hold on. I just dropped my earbud. And I say this basically on every single talk I ever give. I would love to just burn up the whole system, burn it down, and start from scratch. But we know we can't because people need care today and yesterday, and they need it tomorrow. All right, so...
I can't wait to hear this.
I know, right? So my Claude version has said, prior authorization, not because it's the sexiest answer, but because it's the one upstream lever that simultaneously kills patients, burns out physicians, and wastes billions, all while prioritizing and producing zero clinical value.
Ooh.
And that wasn't for me.
Yeah.
It's merely what I read.
Well,
here's how it said it would fix it.
Yeah.
So first, mandate gold carding nationally. Any physician with a 90% approval rate for a given procedure over 12 months gets automatic approval going forward. No review done. Interesting. Second, cap approval windows at 24 hours for urgent requests, 72 hours for standard. Okay. And third, require payers to publish denial rates and overturn rates by procedure and physician category publicly.
Awesome.
Right?
I think actually, Sarah, this is what I all I know about what's going on in D.C. is what I read. But this is there's bipartisan support for two things. One is prior authorization. The other is killing PBMs, which are just, a money-grubbing, worthless...
Marshall, you're going to get us banned on YouTube. You got to stop it.
Okay.
Hold on.
you can go back and edit, right? So
maybe.
But, the value proposition of pharmacy-based pharmacy benefit managers is not in favor of healthcare, in my opinion.
It's tough. There's a lot of different layers to this, for sure.
Yeah.
For sure.
But I love that answer from Claude. That's great.
That's not bad. Thank you, Claude. So here's the same two questions I ask everyone at the end of every episode. So here they are. The first one is, what is the clinical reality that most people in health tech get completely wrong today?
I think it's the reality of how complicated how complicated healthcare itself and the administration of it is, but also how complicated patients are. So you mentioned earlier aging population, more medications, more chronic diseases. If they have a program that's focused on a specific area, it's just not going to be applicable for lots of people. So I think it's both the organizational complexity, but also the complexity of our aging population.
I like that. And then last question, what is the last time you changed your mind about something in healthcare? Now, I'm laughing because as we got on this call, you said, it was 5 minutes ago. But truly, when was the last time you changed your mind?
Oh, it happened all the time. I'm trying to think of a really great example. But one example that was toward the end of my tenure was there was a lot of interest in building more facilities. Mm-hmm. And as we look at it, though, if we succeed in the ways we're trying to succeed, and I think at the end of the day, we need to focus much more on health than healthcare. And if we get our population healthier, then there's not as much need for healthcare. And so I'm a believer that we'll move in that direction. So the idea that we need to build more ambulatory that that's the solution to waiting is the facility, I think is not correct. I don't know about you, but when I was just driving across a sort of suburban area or outside of a suburban area where there were these big buildings that were where insurance companies had been housed, or where various things unrelated to healthcare. They're empty, and
Yep.
you live close to New York City. I mean, I don't know what it stands like now, but after the pandemic, they had all these empty buildings, and so the idea that we might spend $50 million building a building that we don't need. Originally, it sounded pretty good. I thought, well, hey, this might work, and then and this was toward the end of my tenure in my CEO role. Then, although I'd been with it a long time, I finally had to pull the plug and say, we're just not going to do that.
Understood. Well, Dr. Marschall Runge, this has been exactly what I wanted. The institutional reality said plainly from someone who has actually run it. So thank you very much for making the time. For everyone listening, if what we talked about today, the gap between what vendors pitch and what health systems actually need, the accountability question, who gets reached and who doesn't, if any of that landed for you, subscribe to The Clinical Realist wherever you get your podcasts. And if you're working through a real clinical AI question, definitely contact me. I'm Dr. Sarah Matt, and this is The Clinical Realist. See you next week.
Thank you, Sarah.